for Dr. Yasin. Um, yeah, that's mine. Thank you. I must say, when I loaded this talk, it was before he was also going to talk, so I'm definitely not going to repeat all of this. Don't worry, we're almost at the end of it. Thank you for everybody staying. I think we get well into time. I will go through my slides because there's just one or two things I still want to highlight a little bit. Okay, because I was asked to talk about the follow-up of patients and the survivorship of patients, but I think that's a big topic. So that's why I just want to touch on acute things that you guys get confronted with at the clinic that's really can be very serious, and then more long-term things perhaps. Now, okay. So this is the kind of things we are going to talk about. And as we know, everybody is different. So the patients will also have different side effects. And I think the big thing is to sit down with them. And we don't always have the time, but that is why the primary healthcare setting is so important, to sit down with the patients and explain to them again and to try to motivate them to continue with the treatment. And that is sometimes difficult. But if they understand, again, that the benefits outweigh the risks, then they're often more willing to continue with the medication. And that's what I wanted to show you, because we sort of we are a tertiary center, and we're confronted with a lot of new breast cancer patients in a year. Like you could hear from Sister Muri, about 600 a year. So unfortunately, we also don't have the capacity to really follow up all these patients. And that's where we heavily rely on the primary healthcare setting. To help us with these patients. And it's really not difficult. If you do your basic things, you do a proper history, listen to what the patient is worried about, do a examination the way you all have been trained. And then if you worry, to say, okay, now we know we have some tools and we have some contact addresses and telephone numbers after today, to say, okay, I'm worried about this specific patient, I need to send her back. Because most of our patients, if they send out an luminal ALB, they're going to be discharged with their tamoxifen, which we usually use in the premenopausal ladies, or the arimidex in the postmenopausal setting. So they are going to come and they're going to complain about menopausal symptoms. So often if you reassure them and you give them handy tips about how to deal with this hot flushes, and that it will often, I find in practice, after 3 or 4 months, most of the patients are really dealing with it well. But remember, tamoxifen, the two things to look out for is you don't want that patient to develop a DVT or a thrombosis, and you want to know about any vaginal bleeding that they're having. So if she then comes and says, but I'm now getting my periods or it's irregular, then we need to investigate that. And I just find with our patients also, we concentrate so much on the breast cancer that we have to remind them again, you also need a pap test. And we should not forget about that, because that will often sort out the problem. So the patients needs to stay on their tamoxifen. That's the 2 risk factors you look for. That's the most serious. Of course, they can get cataracts as well. Dry vagina is very important. So to ask them about that. But then with the arimidex, remember the most important thing to look out for is some of them will get terrible arthralgia. So they will be really stiff. And I always use that guideline. If somebody tells me they get up in the morning, they're stiff for about half an hour, and then they're coping during the day, most patients can live with that if you explain to them. But there is sometimes that small percentage of ladies that's really stiff and sore the whole day. So it takes away their quality of life. And we don't want that, because then they're going to stop their treatment and then they have a higher risk of recurrence. So those people, I sometimes do change back to tamoxifen. So there would be an indication for that. So if you're not quite sure and you see that this patient is really having a hard time with side effects, you can always contact us and just say, do you think we can switch this patient? And of course, we send our patients with Arimidex home with calcium and vitamin D because we're worried about osteoporosis. So if I get a very elderly lady that's really tiny, typical European features, and I'm worried about osteoporosis anyway, that's another patient that I will not put on Arimidex. I'll put her on tamoxifen. So the other thing I quickly think about in the pharmacies is I've heard from the local clinics, and luckily that was just a couple of times because that's hair raising for me. So the patient are on tamoxifen and then they say, oh, the pharmacy didn't have that, so they gave me the Arimidex. And I think, oh goodness. So if you have problems with stock or anything like that, please also let us know. Because of course we use tamoxifen, for instance, in a first line, and then there's a reason why we switch the patient to Arimidex if they've had metastatic disease. So we really try to pick for a specific patient. So try to keep with that medication. So that's the support needed for the long-term side effects. Now, and then of course we also refer our patients that's palliative. Because we do believe that in their own communities, they will get better care. And Renee also tells me, it's in the specific area that you guys, I'm sure, knows about your hospice and your daycare centers, that you can just remind the patient or remind the family member that is really stressed out and tired that this service is available and help them to access that. Or the social worker that's at our clinic as well, because that's the only way we can do quality of life for those patients and support them. Yeah. So this was really the slide I wanted to talk about a little bit. Let's just see if there's other things. Okay, we already talked about chemotherapy and radiotherapy and tamoxifan's side effects and Arimidex's side effects. Something helpful that we use in our patients that has hot flushes, the first thing that you can try is Dixarit. So it's the same medication that you use for migraine, and they can use that 2 or 3 times a day. That's often the first thing that you try. But if that does not work, then you can prescribe the antidepressant Venlor. It's also difficult for you guys to access that, but if you know about half of the patients that's on 37.5 milligrams of Venlor, it's a low dose, will really have some relief of their hot flushes, and therefore then they will be more motivated to keep on the medication. This is 2 things. Can you see my... So this, I wanted to also just quickly stress, because we've recently seen patients passed away that's on adjuvant chemo. So that means they're busy with chemo because we try to cure them. This is radical treatment, and we really don't expect them to pass away or to have serious side effects. So if you have a patient that is on chemotherapy, still in her treatment program, and she comes to you and she says, oh, I'm feeling terrible, and I perhaps have a fever, and you look in her mouth and there's all kinds of sores in the mouth. There's usually very vague symptoms, but to have a high index of suspicion. And that patient must get a full blood count. So it's not a difficult thing to do, because if you then see that full blood count shows low white cell count and almost non-existing neutrophil count, that you will know that you can contact us immediately. That's an emergency. The patient might have neutropenic sepsis. She can die. She needs isolation. She needs IV antibiotics, all of that. So I always teach my patients that's on chemotherapy to look out for that. And I show them the telephone number of our clinic to phone directly. But sometimes if they're really sick, the family doesn't know, they take them to the local clinic. So whoever sees them there needs to click and say, this patient is on chemo, maybe she's septic. So that's one thing that can save lives. And then the other thing is the vomiting and diarrhea. I hope that you're seeing a lot of our patients are now using Xeloda, which is the tablets that we give them as chemotherapy. But this is small and it's usually safe and it's well tolerated. And even the older patients does well with that. But there's a small percentage of patients that has no enzyme to metabolize that chemotherapy. And usually in the first cycle that they're having, they will start to have severe vomiting and diarrhea and mucositis. It's literally as if the whole inner mucosa is sloughing. So if you have a patient that started on Xeloda and now has lots of diarrhea and vomiting or mouth sores and really struggling, that's also an emergency. So they must be referred to us. I often see that they will dehydrate so quickly and their potassium levels will really fall. And that potassium levels that's low will then cause all kinds of heart problems. So we have unfortunately also lost patients on the Xeloda. So remember about those two emergencies. The late effects we've already talked about. And that is really, it is not as frequent. And I think most of the time we can just reassure our patients that if they have this peripheral neuropathy in their hands, it's going to go away. Sometimes it helps to give them vitamin B12. Sometimes it helps to give them Lyrica for a small course. But most of them, usually during the winter, it's worse, of course, with the cold. So you can say to them about 6 weeks after your, 6 months after the chemo, it should really get better. But we sometimes do get, I've had patients that can't drive their cars now because they can't feel the clutch. So that's terrible if that happens. And then we need to support them now. Definitely not going to go through all these side effects. I just wanted to show you a picture again of one of the radiation machines so that you can also tell a patient that it is not an enclosed space. So a lot of them are worried that they'll be claustrophobic in it. So for us, this is the position our patients lies in, and the machine literally turns around them, and it is done within a few minutes. So can you see there at the bottom? That's actually quite interesting. If I had a video to play, that part of the floor will literally drop as the machine rotates, so that this head that is 20 million rand will not be damaged. So it makes a bit of a noise for the patient, but otherwise they should not be scared about it. And this is photos I also just wanted to show so that patients are reassured. It's supposed to be red and itchy and burning afterwards. And you can also reassure them. And then if they come in a couple of months, it's sometimes a little bit darker as if they've had suntan. But for me, the biggest thing to watch out for is if they've had radiation is to pick up lymphedema earlier than later. And we have a physio also joining us. And your success rate is just so much better if you pick it up earlier. So if you look at the patient's 2 hands and you see a difference, or the patient comes and says, it's a heavy arm, my arm is just heavy, it just doesn't feel right. Rather ask your physiotherapist, and I hope that most of you would have that available at least to consult and to ask. And then if they're struggling, I'm sure they're going to send it on to our clinic. Yeah. So that's what we're aiming for. We aim for when we treat the patient, we're done with the acute treatment, we send them back into their communities where they're living, that they will be able to pick up their lives and go on. And I think with COVID, it has also been different with support groups that has been stopped and all of that. But I think that's where the primary health is so important, and that you can really help us. And I hope some, or hopefully all of you will go away with some tools that you can use, or at least just know there's a team here that you can contact. Our genetic team is also here, and they see patients for us on a regular basis to try to help with that aspect as well, which is great that we can at least offer that to some patients. Because there it says, you are a pivotal part of the success of our treatment, and you can ensure an excellent outcome for our patients if you are motivated to get involved. But it's that balance, I think, that Dr. Yasin also said, not everything that's going to happen to the patient is now the cancer or is now the chemo's fault or the radiation's fault, but it's look at common things commonly. So if that patient has a pain in the arm or in the back and it clears up on your normal methods that you would usually do, then you're happy about that. But if that backache then continues, or the patient loses a lot of weight, or there is some nodules on the scar, or they become more short of breath, or they say, oh, I feel nauseous if I eat all the time, I have pain over my liver. Those kinds of things should make us think, maybe this is not just a normal backache. Maybe I should not give Voltaren for the 5th time. Maybe I should just now look into other reasons. But yeah, so that also comes with practice. That's why it's great if you have somebody senior in your team to also, don't be scared to ask, because we're not supposed to all know. I think it's much more responsible to say, I don't know, so I'm going to ask. No, I do have all the contact details again there for you. And this was actually our holding slide, but I think it was never even on because the talks just went fluently. So, okay.